I'm really thankful, Professor Hamad Athar, for giving me this opportunity. I'm sure you must, uh, I'm hopeful you are hearing my voice clearly.
Yeah.
You're very
Okay.
clear.
So,
You're very clear
so
screen.
I'm just sharing my screen. So, percutaneous nephrotomy, so I'm going to talk a little bit about the anesthetic choices and then the perioperative pain management, current evidence about these blocks, and how we could minimize the postoperative pain management. Just okay. So I have no conflict of interest. So in I've been into the AKU since my residency, and it's been 23 years in Aachen University when I joined as a resident. So in my experience, and Dr. Hamad will also certainly agree that we usually do these cases under general anesthesia exclusively. And there are multiple reasons for this choice of general anesthesia, and I'm going to explain this. But when Dr. Hamad has invited me for this talk, so I searched about that, and I thought, okay, really, is PCNL can be done under spinal anesthesia or local anesthesia. So we have a talk on PCNL under the local anesthesia. So I'm just going to talk about and shed some light on the general anesthesia and regional anesthesia. So choice of anesthesia depends upon patient's preference, the position for surgery favored by the surgeon's surgical expertise, and estimated time of the procedure determined by the stone size, number, and location. So general anesthesia, what it offers advantages is patient's airway is secured in prone position. We have the anesthesiologist has the feasibility to control tidal volumes from the anesthetic machine if surgeon would request that try to reduce the inflation pressure of the lungs so that the access can be facilitated through this maneuver. Then the anesthesia duration can be prolonged, allowing the surgical colleague to make multiple and higher punctures. But there are drawbacks of general anesthesia, and we know these drawbacks. Dr. Ahmad has already mentioned some of the drawbacks. There are drug reactions, atelectasis, tube can be pulled out in prone position. There will be prone postoperative nausea and vomiting, and as I've mentioned, tracheal tube displacement, and that can be disastrous, and hypoxia, and very limited time to change the position of the patient to supine and re-intubate, because it's really difficult to intubate in prone position. Regional anesthesia, especially the regional anesthesia, which is the central neuroaxial anesthesia, that means the spinal anesthesia or a combined spinal epidural anesthesia, it has advantages. And regional anesthesia for PCNL was first described in 1988. And there are few advantages of the regional anesthesia, and this is less postoperative pain, less blood loss, early recovery and discharge, thereby reducing a stay in the hospital. But drawbacks is that uh, the precipitated the patients with comorbids, there is a risk of sudden hypotension after making the patient prone, and patient discomfort increases with the duration of the procedure, and the surgeon may not feel comfortable in making skin punctures, especially those close to the 11th rib, if the patient is unable to coordinate breath holding at the time. So sometimes there is difficulty to control hemodynamics in susceptible patient. If procedure gets prolonged, if there is a prolonged bleeding, if there is an excessive bleeding, so there is difficulty to control hemodynamics. So this has some drawbacks, regional anesthesia. But of course, certainly there are centers, there are people who are doing PCNL under spinal anesthesia, and they have these expertise and doing this in this sort of fashion. So current evidence about the general anesthesia or regional anesthesia is Mehrabi and Shirazi. It's published in the Journal of Urology, and they have evaluated the intraoperative and postoperative anesthetic and surgical outcomes in patients who underwent PCNL under spinal anesthesia in prone position. And they concluded that spinal anesthesia is not only safe and effective for performing PCNL, but it is is also a good alternative for general anesthesia in adult patients. Another study, which is published in Egyptian Journal of Anesthesia in 2015, it's a randomized controlled trial that includes 200 patients who compared the efficacy of general anesthesia versus regional anesthesia in PCNL patients, and they concluded that both the groups had comparable intraoperative hemodynamics. One of the other study in urology, in a large retrospective study, they involved the 1,004 patients, and the complications were graded according to the Clavian classification. Complications was greater in the general anesthesia. So this is a meta-analysis of the randomized controlled trials, which is published in the 2018, and they looked at the 9 prospective RCTs, concluding 858 patients, which compared the use of regional anesthesia to general anesthesia in PCNL. And what regional anesthesia, what they conclude based on this trial, the meta-analysis, that regional anesthesia could reduce the operative time, it could reduce the hospital stay, the VAS pain score for pain relief, visual analog scale for pain relief on first and third post-op day. The analgesic requirements are less, and less nausea and vomiting. However, there is no significant differences between regional anesthesia and general anesthesia groups in terms of stone-free rate, blood transfusion, and post-operative fever rate. So another recent meta-analysis which compared the general anesthesia versus spinal anesthesia and PCNL, which is published in 2023, they evaluated 4 RCTs and 7 retrospective studies. And in their assessment, general anesthesia is superior in terms of lower Clavian Dindo grade 2 complications, transfusion rate, and UTI occurrence. And spinal anesthesia is superior in terms of shorter operation time, fluoroscopy time, length of stay, and a significantly lower frequency of post-operative headaches. So what they conclude is that both methods are similar in terms of the overall complication rate. Therefore, the decision to choose between general anesthesia and spinal anesthesia should be based on the patient's clinical parameters and the surgical team's preference. Because it's always a difficult task for the patient to remain prone, awake in a longer duration of time. Now, the another part of my talk, another component of my talk is the acute postoperative pain after PCNL. And as earlier Dr. Hamad mentioned, that the pain is mainly associated with the severe postoperative somatosensory and visceral pain. The renal pain originates from the T10L1 spinal nerve, and the urethral pain originates from the T10 to L2 spinal nerve. However, the incisions and pathways are typically formed under the 12th rib or between the 10th and 11th ribs, where a cutaneous innervation is mainly undertaken by the T10 to T11. So, risk factors which are important for moderate to severe postoperative pain in patients with PCNL are diameter of the renal calculus, residual calculus, duration of surgery, number of renal calculi. So current pain regimens after PCNL, especially the urology-led pain regimens for PCNL in perioperative or especially the post-operative, is the one of the technique which I just touched. I just looked at is the tubeless PCNL, which has some pros and cons. It is intraoperatively, it is a urology-led intervention, so may increase post-operative infection. Opioid analgesics, these are the mainstay of pain management in perioperatively and post-operatively. But we know there is an opioid endemic, opioid crisis in North America and the other parts of the world. So the emphasis currently on to reduce this opioid use in patients because of the increasing addiction rates. So paracetamol is very easily available. Intravenous paracetamol is available, lower postoperative opioid consumption, and it is potentially expensive, but not in our part of the world. In our country, it's not very expensive. Local anesthetic infiltration, yes, urologists sometimes do peritubal infiltration. There are comparisons published regarding the erector spinae block compared to the peritubal infiltration, quadratus lumborum block compared to peritubal infiltration of the local anesthetic, but we don't know the effectiveness, so there is questionable effectiveness. So a multimodal approach using the localized techniques and non-opioid drugs is favored for post-operative analgesia to reduce unwanted effects related to opioids. Trends in post-operative pain treatment have shifted from the epidural anesthesia to newer regional blocks, which may be easier to administer and have associated risk. So as I do renal anesthesia more, I have a particular interest to do ultrasound guided blocks. There are many blocks which are used for post-op perioperative pain management, and there are blocks in which we also do some surgical anesthesia for limb surgeries. So if we go through from the center to the peripheral for this PCNL perioperative pain management, as I have mentioned in my last slide, that we really don't need epidural or a central neuroaxial analgesic modality like epidural. So going towards periphery, there is a erector spinae muscle, and I'm going to talk about this erector spinae block. So you can do a paravertebral or an erector spinae. Most likely, more people, the anesthesiologists and the renal anesthesia community have really going towards this block for multiple of indications, this erector spinae block. Then we have a quadratus lumborum block, and then you can also further go or more peripherally to the lateral abdominal wall to do a tab block. But tab block does not have certain efficacy in PCNL because it does not cover those nerves to by the which are involved in the pain management in the pain originated from the PCNL. So if so, as I have searched for this talk, I found an article which is also which said that anesthesia-led pain regimens for PCNL. So as I have mentioned, epidural block, paravertebral block, erector spinae plane block, quadratus lumborum block, and transverse abdominis block. So my emphasis on these two blocks, which equally published in journals of urology and equally published in anesthesia journals for specifically for PCNL. So let's talk about the erector spinae pain plane block. And so erector spinae group of muscles, these comprise a group of muscles which include the iliocostalis, longissimus, and spinalis muscle, and they run bilaterally from the skull to the pelvis and sacral region, and from the spinous to the transverse process extending to the ribs. So there are multiple indications for erector spinae block, and this block actually is a newer one. It comes in 2016. It has first been uh, performed by the Ferrero in the 2016. So if we need a erector spinae plane block for rib fractures, we usually perform at T4 or T5 level. If we need something for radical nephrectomy or PCNL, the T10 is T10 or T11 is a usual place to do this block. And then erector spinae plane block has now been also started in the lumbar spine surgery. So an L2, L3 L2, L3 transverse process, we can do as ESP block for lumbar spine surgery pain management. So what I know the audience of this platform is mostly belonging to the urology, but just go a few slides about and few basic maneuvers and basic steps in putting these blocks, which are, and I'm going to talk about the ultrasound guided because the advancement in these blocks and the safety of these blocks lies doing it in ultrasound guided blocks. So patient position is usually either sitting, or probably the best in PCNL is to do one once the patient is prone, and you can do a very good erector spinae plane block in prone position. Then you have a surface anatomy or a functional anatomy in which you can see the trapezius rhomboid and the erector spinae muscle. And when the probe is moved from the lateral to the medial side, once first comes the ribs and then comes the square shaped transverse process where the erector spinae muscle is attached, and then insert the needle in plane, the ultrasound guidance, and then you can do erector spinae plane block, give the local anesthetics. First you give the hydrodissection through the normal normal saline, and then you can do 20 to 30 mLs of local anesthetic of bupivacaine 0.25% or 0.375% or ropivacaine 0.5% or 0.25%. Usually we use 0.25% in a concentration for analgesia. So this way, this block can be done for PCNL, and there are current evidence. There are multiple. When I search on PubMed, about 3 pages of PubMed are came up with the different studies. So I picked a few which are recent and which have some conclusion, like this study which is published in the 2023 in the Turkish Journal of Anesthesiology and Reanimation, the efficacy of erector spinae plane block for patients undergoing PCNL. It's a randomized, controlled, and open label study in which 64 patients were analyzed. Remifentanil consumption of the control group was found to be significantly higher pain scores between the 30th minute and 24 hours in the control group. Erector spinae plane block reduce intraoperative opioid consumption, reduce the need for rescue analgesia, and postoperative pain scores. Another study which is published in Curious is the should the erector spinae plane block be applied in the pain management of percutaneous nephrolithotomy. Prospective randomized control study. They aim to investigate the efficacy and respiratory effects of postoperative pain management. 15 ml of 0.5% bupivacaine at the T11 level was administered preoperatively using the in-plane technique. A significantly lower visual analog scale and dynamic visual analog scale were observed. Again, in the Journal of Urology, efficiency and safety of erector spinae plane block, it's a meta-analysis based on the randomized controlled trials. 14 studies were identified after database searching. 6 studies were included in the quantitative analysis. Overall, erector spinae plane block could significantly reduce the postoperative short time. It showed its advantages in less intraoperative fentanyl use, decreased total tramadol paracetamol consumption postoperatively, and there is longer time to first rescue analgesia. Another block which is also a peripheral nerve block which can be done is the quadratus lumborum block. And quadratus lumborum block is the quadratus lumborum muscle lies in the posterior abdominal wall, dorsolateral to the psoas major muscle. It originates from the posterior part of the iliac crest and the iliolumbar ligament, and inserts on the 12th rib and the transverse process of vertebra L1, L4. Now the sensory, different parts of sensory block have been described. So there are 3 approaches of quadratus lumborum block, which is QL1, QL2, and the anterior or QL3 or transmuscular. So the primarily the QL3 or the anterior quadratus lumborum or the transmuscular one is the choice of quadratus lumborum block, which is usually done for the perioperative and postoperative pain management in the PCNL. So these are the 3 approaches which I have shown in this figure. Again, the patient can is the superlateral position is preferred. Then the lateral decubitus position is preferred over the supine position. We place the transducer in a transfer orientation on the patient's flank, just cranial to the iliac crest. Identify the acoustic shadow of the LL4 transverse process. Now, there is important information which I need to share, that this is a deep block. So this requires a curvilinear probe to image the quadratus lumborum muscle and the psoas major muscle. So it requires a curvilinear probe to do this block. And then identify the acoustic shadow of the L4 transverse process and the erector spinae muscle. Then insert the needle in the posterior to anterior direction through the quadratus lumborum block. So I'm not going into the detail because it's not worthy mentioning of all the details of this block. But what we need to see is the current evidence regarding QL block and PCNL. Again, Turkish Journal of Anesthesiology in 2018, the quadratus lumborum block 3, which is the transmuscular or the anterior QL block, the prospective randomized double-blinded study, 44 patients who have undergone elective PCNL under spinal anesthesia. The postoperative visual analog score was found to be statistically significantly higher at the 8th, 12th, and 24th hour in group where the this block is performed. Again, the quadratus lumborum block for patients in percutaneous nephrolithotomy, a randomized control study, which is published in Anesthesia Essays and Researches in 2021. 40 patients for unilateral PCNL under spinal anesthesia, ultrasound guided posterior QLB with 30 ml of either 0.2% ropivacaine or normal saline. Duration of analgesia was significantly longer, lower VAS scores, patient satisfaction was better, and analgesic consumption was lower in QL. So efficiency and safety of quadratus lumborum block, again, this is published in Urolithiasis. 9 RCTs are included in the meta-analysis. There is lower opioid consumption, less in visual analog scale, and shorter hospital stay. Opioid sparing analgesic. So now what I again search for to find out any comparisons of erector spinae block with quadratus lumborum block between these two blocks, but I couldn't found a published study. This is a systematic review which is published in Journal of Endourology, in which this opioid sparing analgesic effects of peripheral nerve blocks and PCNL, and 17 trials were evaluated, in which 1012 procedures were included. 5 different blocks were identified and evaluated, in which paravertebral, intercostal, quadratus lumborum, transversus abdominis, and erector spinae. 9 of 16 studies observed lower pain scores with peripheral nerve block used throughout the 24-hour postoperative period. So there are comparisons of efficacy of erector spinal plane block with peritubal infiltration. There are comparisons, but only I could find this which is registered on the good clinical practice. So someone is doing this study on anterior quadratus lumborum block versus erector spinae plane block in percutaneous nephrolithotomy. This is, I think, it's a protocol which is registered at this site, so we don't have any comparisons, so it's a good time. So do a study in our setup as well, or at least we can do a study on. So what, as a regional anesthesia person, as a regional anesthesia anesthesiologist, I choose to prefer erector spinae because QL block is a relatively deep and it has some disadvantages. It has some complications, which is very dreaded complications. ESP can be done easily in a prone position when the patient is under general anesthesia. So block during the performance, patient does not feel much pain. So in conclusion, postoperative pain after PCNL has significantly unfavorable consequences on postoperative rehabilitation, quality of life, and economic and social situations for patients. Peripheral nerve blocks may offer a significant opioid sparing analgesic effect during postoperative recovery after PCNL. Thank you so much. And once again, I'm very thankful to Dr. Hamad for giving me this opportunity.
Thank you, Faisal, for a very comprehensive review and sharing the anatomical details.